having tools or resources, quick handouts that they can give the patients that's like an easy guide. I think it's important to find out the patient needs, how do they learn best? But the nurses also wanted quick reference guides, just an overview of what the indication is and what needs to be done prior to ordering this. It's nice also, not only have it written out, but just a little like cartoon, for lack of a better description, to make it easy to understand, but also then translate that to the patient.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jamie Weimer, Oncology Clinical Specialist at ONS. And today we are talking with ONS member Paula Anastasia, Clinical Nurse Specialist for UCLA Health in Los Angeles, California, about the knowledge gaps and barriers to practice for nurses who are caring for patients newly diagnosed with ovarian cancer. Paula facilitated an ONS focus group on the topic on July 29th, 2022, and we'll be discussing the findings, specifically biomarker testing and terminology, PARP inhibitor therapy, and oral medication adherence. This podcast episode is supported by a sponsorship from AstraZeneca. ONS is solely responsible for the criteria, objectives, content, quality, and scientific integrity of its programs and publications. Thanks for joining me today, Paula.
Thank you so much, Jamie. I look forward to this.
So you and I actually collaborated on hosting this virtual focus group together as facilitator and moderator to talk with nurses who work closely with those patients newly diagnosed with ovarian cancer, and to understand what realistic current practice is like and how the integration of targeted therapy has changed that landscape in gynecologic oncology. To start, can you give us a little context about the focus group participants? What roles, backgrounds, and locations did they represent? And what were the group's overall goals?
We had a variety of nursing experience. These were nurses who volunteered. We reached out on ONS platforms for any nurse that wanted to be a part of this focus group that needed or wanted more knowledge for ovarian cancer and PARP inhibitors and biomarkers. And we had 20 registered nurses, various degrees, BSN, advanced practice, and we had 2 that had doctorate degrees. The mix of practices was medical oncology, GYN oncology, and we even had a nurse with radiation oncology. Their roles were as vast as where they were in the country, from East Coast, West Coast, Midwest. We had nurse navigators, clinical nurses, coordinators, nurse educators, and managers. So it was a great group of passionate nurses wanting to share and learn.
It was a great group, and we really had a nice representation of lots of different areas. So now let's look at the focus group's first discussion point, which was the use of biomarker testing in the diagnosis and treatment decision-making. Can you briefly explain what the current landscape of biomarker use is in ovarian cancer?
Historically, the serum blood test, CA-125, this was previously called a tumor marker. It is now referred to as a biomarker. It is used as one measure of a clinical response to treatment for ovarian cancer. And let me just preface this. When I say ovarian cancer, I'm also including fallopian tube cancer and primary peritoneal carcinoma. So we group those together, even though they're individual diseases, but we usually lump those when we say ovarian cancer. So the CA-125 is a biomarker, and it's used as a response measure for women who have an elevated CA-125 at the time of diagnosis. And it's not elevated in all patients, nor should it be used as a screening test. In addition, since 1995, we've had the ability to identify germline pathogenic variants in the BRCA1 and 2 tumor suppressor genes. And this has allowed early screening for detection and or secondary cancer preventions, which includes risk-reducing surgery for these women that have BRCA1 and 2 pathogenic variants or mutations, as they were previously called. It also promotes cascade testing, which includes testing the family members and perhaps preventing future cancers in these families. We now recommend update and or panel testing. So we're doing more than just BRCA1 and 2, but we're doing this whole panel of genes where more than just the BRCA1 and 2 are identified. Germline testing is recommended for all women with ovarian cancer, regardless of ethnicity or race, because this can dictate future treatment options, especially with these PARP inhibitors that we're going to be talking about. Somatic testing, on the other hand, is where we test the tumor for a variant, mutation, or a typo, whatever word you prefer to use. And we call this molecular profiling. And this is acquired, meaning it's not inherited like the germline that we do with blood and saliva to identify the BRCA1 or 2 variant. And when we're doing molecular profiling for somatic, we're looking for many targets, but commonly we're looking for alterations in the DNA repair pathway called homologous recombinant deficiency. Since that's a mouthful, we just say HRD, and we're looking for a deficiency in this pathway. And this information is also useful for treatment decisions, especially with the PARP inhibitors. And we found in this focus group that nurses still needed clarity of terminology and the rationale for germline and somatic/HRD testing. And they all shared that those that work in the infusion center in general med offices, as opposed to the specific GYN oncology clinics, that they weren't as familiar with somatic and HRD terminology as you would suspect.
Wow. So clearly the use of biomarkers in ovarian cancer has gone through a pretty significant shift over the years. How did the nurses in the focus group, did they describe their role in helping to obtain biomarker testing? What was their role in that process?
It's so interesting because there are so many different roles in practice settings. And of course, the physician or even the APP will order these tests. And it was discussed that germline testing in determining which panel to order, it was not consistent, nor which company would they use. In facilities that were fortunate enough to have a genetic counselor on site, the genetic counselor usually would make the decisions of what panel and or which company. But most nurses did agree that the providers use the same company out of habit and familiarity.
In talking with the nurses during the focus group, you had mentioned already some of the knowledge gaps maybe, but we can kind of revisit those. What were the knowledge gaps overall that the group identified in terms of familiarity with biomarkers and how they're used in making treatment decisions for ovarian cancer?
Well, it was not unexpected that the nurses that work in the GYN oncology focus practice, they were the most familiar because this is what they did every day, as opposed to a med-onc setting where they may only see a handful of patients with ovarian cancer over the course of a year, as opposed to a GYN oncology specific group. They did all express that the understanding of when to do germline testing, when to do the somatic biomarker, they weren't really sure when it should be done and who's doing it. Clearly, the infusion nurses were less likely to be familiar with biomarker terminology for PARP inhibitors, and understandably, because infusion nurses are giving IV therapy, not oral therapy. But it was interesting because there is an indication for using IV bevacizumab with an oral PARP inhibitor. So these nurses in the infusion center may be giving the IV bevacizumab, but not necessarily knowing or understanding why this patient is also on a PARP inhibitor. So these were some of the gaps in knowledge that were reported.
Well, and you bring up a great point as we start to see more and more multimodality treatments that span different areas of where we conduct cancer care, different departments, different buildings, sometimes different units. It does become important to understand what knowledge each group of nurses already knows, needs to know, and how we can improve that, which I think was part of the whole reason we did this focus group. So that was really interesting to learn from those participants. So along those same lines, what barriers or challenges did they share related to conducting biomarker testing, obtaining results? What were the pain points for them?
I'm glad you asked this question because as cancer care is evolving and patients are living longer and better, I think it's we nurses that are actually the ones that are doing these behind the scenes. The most common barriers discussed were consistently across the board with cost and insurance approvals. And respectfully, we're the ones that are doing this, not the physicians and not the prescribers. Other issues were access to the results. So results are not always being uploaded into the patient's medical record. I know I sound like I'm like complaining here, but these are like real life scenarios where those of us in busy practices, it's like, okay, where do we find these results? We need a source document to confirm and why this patient is going to be getting this treatment. But there are online portals for ordering, whether the nurse is doing this, the physician, the APP, and then who gets those results. So only one person may have that result, but it's not shared or uploaded for everyone to see. So these were just common nagging frustrations that were consistently discussed, but also the cost and needing to have peer-to-peers and overcoming the denial and the insurance authorizations.
It's a reality, right? It's a reality in our ambulatory-based practices where we didn't go to nursing school for this, right? Like this isn't what we were trained to do, but it is an integral part to making sure that our patients get the care that they need. And so it's one of those things that nurses step up to the plate and get it done because there might not be anybody else to do it. I agree that it was a common frustration of getting the test results where they need to be in terms of in their medical record, whether it's electronic or some other system, and just those logistical access issues, even for the clinicians, I think were surprising for me to hear that we're still kind of dealing with this, even though so much has become digitized. So after hearing everyone's sort of barriers, challenges, things that they think could go better, what were some of the group's recommendations for kind of top priorities of how things could change or improve regarding biomarker testing?
Well, one of the issues the nurse identified was the need for better access to genetic counselors and counseling. And those of us that work in an academic setting, we're fortunate because oftentimes we do have a genetic counselor on site or somewhere in that facility that we can utilize. But that's not, again, across the country, not everybody has that. And then the other thing is, how do they find one? I do have a great plug, and I try to educate my peers on this. The National Society of Genetic Counselors, they have an online website where you can go in and put your location, and they will assist in doing telemedicine, ordering, giving results, and counseling. So that's a great resource. But again, the nurses did identify that not everybody had the luxury of having a genetic counselor, and then the update paneling. So patients that may have had genetic testing in the early 90s, they only may have tested for one or two different pathogenic variants, as opposed to since 2015, we are now doing multi-gene panels. So again, patients that had a long disease-free interval, nurses may not be familiar with this new concept. And that's where the genetic counselors are so important. They also suggest that they need information on targeted treatments, but really quick and easy, those pearls of knowledge and which biomarkers were relevant to their practice. They were interested in a simple description of PARP inhibitor mechanism of action and their relevance to which biomarker and DNA pathway. They also recommended a handout that they could give to patients to explain it in a very simple term. And again, some patients want more information, some want limited, but all patients need some information. They again shared the need for improved interoperability of testing order system, and again, how to access these results so that they were in one place for all to access.
That's great information and recommendations that they shared. I think the points about education that can be easily explained and translated to patients, it relates directly to the request for more information to help us as nurses educate ourselves. It's kind of like the airline. You have to put on your own mask first before you put someone else's on. If we don't, as nurses, don't have a good working knowledge of what this mechanism of action is or how these targeted therapies function, it's harder for us to translate that in a way that patients can kind of grasp onto. So it is a two-layered need of both education that supports our nurses as this science evolves quickly, but then also finding ways to translate that to patients that is meaningful and is something they can retain. great outcome from that first topic. Then our focus group kind of transitioned into sort of our second session where we talked specifically about PARP inhibitors as frontline maintenance therapy for ovarian cancer. What foundational knowledge is critical for all nurses as their role in working with PARP inhibitors and truly lots of targeted therapies? What's that foundational knowledge that's critical for them to care for their patients?
Since the nurses had such a various and broad practice setting, not all the nurses were current on indications for PARP inhibitors in the maintenance setting. And the practices, they were consistent in the sense that patients would receive a specific PARP inhibitor if the patient had a germline or somatic pathogenic variant. There were variations in practice in which patients received, as I previously mentioned, bevacizumab in the upfront setting, followed by the combination of bevacizumab and a PARP inhibitor. And there were also discrepancies in practice settings for how long a patient would remain on a PARP inhibitor. That was really interesting. Some providers continued PARP inhibitors until progression, as opposed to the FDA recommendation for 2 years for olaparib and 3 years for niraparib. And not all nurses could identify the different indications for primary maintenance or first relapse maintenance. But again, this was the purpose of the focus group, to gain more knowledge. So it was a really great give and take information session.
Were there any additional knowledge gaps that the nurses identified regarding the use of PARP inhibitor therapy?
Well, they were very knowledgeable with respect to common side effects of PARP inhibitors and their management. I mean, I think that we collectively, that's what we are really good at. However, they were less confident on the specific indications with somatic or HRD testing. And again, this is pretty new when you think about it. I mean, we've been doing germline testing, but somatic and HRD testing is really relatively new. So they discussed wanting more knowledge of the mechanism of action with PARP inhibitors and how that alteration benefits patients with germline or somatic mutations. And most nurses did agree that their patients were offered germline testing, again, at the time of diagnosis, but they were unclear as to when somatic or HRD testing was being done. Because remember, this is testing the tumor. So who does that? The physician may, pathologists may, advanced practice nurses may be ordering it. So it's not necessarily consistent, like we have a genetic counselor helping and assisting us. It was very inconsistent. So not all nurses knew where to find these results or to even know if it was done. There was heated frustration verbalized. That was probably the biggest barrier in the practice setting was it done and where to find the information for HRD and somatic testing.
That is a challenge that sometimes feels insurmountable with the variations in electronic health record systems and just the complexity of updating and changing those systems. So that pain was felt. I agree with you. So at the conclusion of that session, specifically talking about the PARP inhibitors, did they come up with any final recommendations or priorities on things that they would like to see improve or change to improve the care they provide?
Education was key, and they all agreed that it was important to identify who the appropriate patient would be that would most likely to receive a clinical benefit, and in addition to not just a clinical benefit, but who also would be following through or maintaining oral adherence. It was recommended to reinforce the side effects with the patients, especially the class effects that may occur for the first 2 months and usually will plateau over time. And that would include nausea, fatigue, and some hematological side effects, but really to emphasize this to the patient and that to report to the practitioner so that we can help mitigate these symptoms. It was recommended to inform patients that there may also be a need to dose hold or dose reduce, as one size does not fit all. And that would be based on the side effect and the blood panel results. It was determined that patients should be informed that the goal of treatment of maintenance therapy was to prevent or decrease risk of recurrence. Now, none of us use the word cure, but it was really important to give the patients the etiology or the goal for this therapy. Patients will be monitored weekly or monthly, depending on which medication was recommended, and that they would require routine exams. Some offices mandated in person, or others would allow telemedicine. But again, education and letting the patient know what the plan is. Most nurses also agreed that patients were allowed treatment breaks for a couple of weeks if they had a special event or a vacation, despite having no evidence-based practice to back up that rationale. But they did say in their practice, they really listened to the patients, and those patients sometimes just really needed to have a break in order to enjoy, again, a special event or a holiday.
And the discussion as it naturally evolved into the symptom management and the side effect profile, that led us quite smoothly into our final topic of the focus group, which was discussing oral medication adherence. So what challenges did the nurses share about promoting adherence for their patients that were taking PARP inhibitors for that long duration in the maintenance phase?
Well, it's interesting because I think when dealing with women with ovarian cancer, because most of these ladies are identified in the late stage and the limited survival, but we are increasing that long-term survival, the majority of nurses did believe that the patients were intentionally adherent and motivated in taking their prescribed medication, obviously, since the goal was to increase survival. But it's interesting because as we say that, and then as we work through, it was still kind of like, well, they've missed doses or they want a treatment break, that sort of thing. But some of the nurses were fortunate enough to have designated clinic and nurses that followed up with patients weekly who are on oral medication. So they have a designated clinic and a designated nurse for that. So obviously, these patients are going to have much better outcomes. It was recommended to assess patient adherence by asking open-ended questions, and the nurses were coming up with different strategies, but they all agreed that the most common question to ask the patient would be, how many doses did you miss this week or this month? Recognizing that people miss doses and it's not necessarily intentional, but it does happen. So validating and giving them permission to be honest with us. But we also want to know what are the reasons for missing medications. And the most common patient response was either forgetfulness or fatigue. So delving into the causes and again, how to help and mitigate that as well.
I think that was an excellent point that came up, as I think the sort of the gut reaction question is, are you taking your medications? And, we know that the dutiful patient who will want to do what they think they're supposed to do, they will say, yes, of course I'm taking my medications. But we know that that's not reality and that we want to normalize that it's okay. We know that you're not a perfect human and that you'll miss a dose. And that's okay. We want your honesty so we can help improve that adherence if there is a challenge. So I really appreciated that discussion. And I think our participants really learned from that exchange of how even just asking a question slightly different could perhaps elicit different responses from patients. So I thought that was really valuable. Let's discuss what else did the group bring up about some of their patient struggles with adherence. Did they have any recommendations of how to make that better or improve that for their patients?
In general, like you said, the nurses did agree that most patients were adherent and taking their PARP inhibitors correctly. Now, remember, olaparib is BID and niraparib is daily. So they did discuss the importance of assessing their patient before therapy to identify if there would be any red flag barriers. But other issues included in that barrier not of being adherent would be, in the very beginning, it's the financial and the copays. So initially, patients are, I'm going to do whatever. But I'm not kidding. The copays can be zero to many, many thousands of dollars. So patients have borrowed money, and we have talked in this focus group about ways to help our patients with copay assistance, but patients also can be very proud. But sometimes patients can get copay assistance or grants, but they may run out. Maybe after a year, they're not as adherent because of a financial burden. So these were important to discuss. Also, when we want frequent laboratory, for niraparib, we're checking their labs weekly. For the first month. For olaparib, we're checking it monthly. So again, access to patients going to the lab, transportation, those sort of things. One of the benefits of oral medication is you don't have to come into the clinic, but we also need to have labs drawn. So there are patients that have transportation issues. So those were barriers too. So just the social backgrounds of patients were some of the barriers. Safe storage, are they taking them? Cognitive, those types of things. The group were, oh my gosh, they were just so passionate and energetic about some of the tools that they use to improve, especially with BID dosing. Some had calendars, provided pill boxes, some had the patient-reported outcomes, text message reminders. There were even some of the nurses that were doing it for the patients, obviously involve caregivers, family, friends. There are apps that can be downloaded for reminders. Now, not every patient has the luxury or the skill of having a smartphone. So again, you could use more old-fashioned things like calendars and pill boxes, but they were offering lots of ideas, which was really helpful for everybody. But in general, the group felt that the side effects were the largest reason for non-adherence, and therefore patients would be encouraged to take a break or have dose titration. It was interesting because, at least a third of them were down dosing and then going up, whereas others would follow the recommendation to dose reduce based on either patients' interference with ADLs, where they had a grade 2 or grade 3 fatigue, or a grade 2 hematologic toxicity, or an adverse event. But the irony was when patients needed to be dose held or dose reduced due to a side effect, they usually were reluctant as they were afraid of a decreased outcome in survival if they dose reduced. That was very interesting. So again, educating, talking to patients, finding out their value system, what's important to them, but also giving them the information up front so they understand that one size does not fit all. Sometimes we do need to dose reduce you, and you can still have an excellent clinical benefit.
Absolutely. And that education piece was a recurring theme throughout all of this is, when do you bring up the education and the discussion about maintenance therapy that starts after your frontline therapy? And when do you bring it up? When do you reinforce it? And then also, as you just mentioned, helping to prepare them to kind of shift their thinking of that, unlike upfront chemotherapy where, staying on schedule has a different implication. Sometimes these longer maintenance therapies, there might be a little bit more kind of give and take in terms of taking dose breaks or dose reducing to find that kind of perfect dose just for them. So that right there is one part of the patient education process that is so critical when you're coaching patients through this transition to maintenance therapy. So how did the different institutions represented in our group, did they approach that process like patient education?
Well, it's so interesting, as we know, that not all nursing clinics are created equal. Some nurses had support teams, including patient navigators, advanced practice providers, and staff nurses. There was shared patient management. A few clinics, as I mentioned, had the designated nurses who managed only patients taking oral medications. Oh, how I wish we had that. Those clinics obviously had positive outcomes for patient satisfaction. There was a lot of dialogue regarding specialty pharmacies, which was interesting, as these specialty pharmacies will provide extra benefits of telemedicine, telenursing to patients that are on PARP inhibitors. And several times a month, they'll call and ask the patient about the side effects. The majority of the nurses in this focus group found that this third-party unsolicited follow-up service was confusing to the patient and the nurse provider. The patients who were reporting to the third-party nursing support service was not always reporting the same information to the primary care provider. So that was really interesting. Obviously, no surprise, the nurses were unanimous in reporting increased stress, increased workload, and not having enough time to keep up with all the new drug indications or the medication side effects. Ordering tests, locating the tests, this was so time consuming, and this is where a lot of their reporting of frustration came in. And again, not all departments have a designated person or department to obtain authorization. So sometimes these nurses or practitioners were doing quote unquote everything. They were interested in having pearls of knowledge or quick reference guides for the pertinent information for both themselves and the patients. So the patient education and the repetitive patient education, so if you know that patients don't remember everything that we tell them in the very beginning, and it needs to be again, reinforced. It's a high priority. We all agreed with that, but it's also time consuming for these nurses who have increased workloads and responsibility. So I think that really came out.
And you bring up an excellent point. The pace at which all of these new drug approvals or added indications to previously approved drugs, it's outpacing what we can consume, I think, as practitioners, given, as you mentioned, and as our participants described, just all the other things they're doing in a day and how sometimes at the end of the day, there's not 1 minute left to invest in themselves, to update their education level or learn about a new drug. They're prescribing it the day, after it is approved. And so that was, I think, an important point that was brought up and emphasized by our nurses is that obviously the desire to know and understand is there, but they feel kind of like they're drowning right now in everything else. And so it just feels like that one more thing. Did they give ideas or suggestions on what might help them feel more confident? Or what do you think would help make them feel more confident when trying to have these education discussions with patients?
Well, I think having tools or resources that are quick handouts that they can give the patients, that's like an easy guide, and then they can review it with the patient, but then the patient, if they have questions, can follow up. I think it's important to find out the patient needs. How do they learn best? On a video or paper, that sort of thing. And again, you have language barriers, you have different education levels, but the nurses also wanted quick reference guides. I think that was really important. Just an overview of what the indication is and what needs to be done prior to ordering this. So you need to have biomarker testing, and these results will dictate which medication. And then a quick mechanism of action. I mean, just learning all the different mechanisms of action of all these medications and immunotherapy. It's nice also, not only have it written out, but just a little like cartoon, for lack of a better description, to make it easy to understand, but also then translate that to the patient. And you don't have to go in detail, but just something that just really adds to the ease of learning.
Absolutely. I remember one of our participants pulled out off of her desk, showed in front of our camera. Like this was a 3-page kind of foldout that she had received previously she couldn't remember if it was at ONS Congress or in one of her journals, but it was a reference that she had received that she used to help describe the different types of therapy and how chemotherapy and immunotherapy and targeted therapy sort of are different. And so that visual, she still keeps handy because that's her go-to. And so I agree. I think that they were hungry for those kind of quick little examples, those visuals that are simple to understand, but that create sort of a connection for both nurses and patients of like, here's what this means. I think clearly we learned so much from this focus group. How are these focus group findings going to be used and shape ONS's future clinical priorities?
Unsolicited, I'm just grateful to ONS because ONS really wants to give us education and confidence to be patient champions. And I think the next step is to review this information, internal ONS clinical learning and development teams, in ways to identify and meet the needs that provide the information our ONS members want. And that's what ONS does. It's like the best resource for us. So I think that going forward, they're going to use this information to help us provide better tools to help our patients and help us to be less frustrated.
Absolutely. And I think I can't say enough of the value of having those nurses give us their time and give us that feedback in that focus group, that live discussion where they not only help us to learn what their experiences are like, but also they learn from each other. They took notes and they were able to network and socialize that we are all living the same life, but with differences. And so how can we borrow from each other's practices, triumphs, challenges? How can we use that information to care better for our patients wherever we are across the nation? So that was just really exciting to see. And I really enjoyed that focus group format to get that live, real feedback from nurses who are doing that work every day. Okay, so as we approach the conclusion of our episode today, we like to always ask a quick series of questions just to help summarize our discussion here on the podcast today. So first off, what are some common misconceptions about implementing and using biomarker testing and PARP inhibitor therapy?
Well, I think as previously mentioned, who does the ordering? And was it the nurse, the APP, the physician, the pathologies? And this is really inconsistent in different offices. So I think knowing who's doing the ordering and then not knowing when it is done. So from somatic and HRD, has it been done and where to find the results? I think that's really important for nurses to feel competent in going forward with educating their patients as to why they're being prescribed a PARP inhibitor. But also misconceptions is, I want to say the olden days because that's me, but currently, today, going forward, all women with ovarian cancer need to have germline testing to determine if there's a identifiable pathogenic variant. And this includes all ethnic and ancestry group. This is still not being done. And you talk about healthcare disparities. All women, regardless of socioeconomic, regardless of color of their skin, and where their ancestors are from, need to have genetic testing because this is going to help dictate treatment options for PARP inhibitors. And they all agreed that most women with ovarian cancer, the nurses in the focus group agreed that most women with ovarian cancer will receive a PARP inhibitor in their first or second maintenance setting based on the biomarker testing. So that's why it's so important to, at the very beginning, we need to have this testing done.
That's very important. And you're right. That wasn't always the way it was done. That used to be a certain category were eligible to get that testing. And now that it's all comers, that's an important point to emphasize of how that has changed. Okay, so what else? What's something about PARP inhibitor therapy that's not often discussed or not commonly known, but you wish people knew more about?
Well, I think we know that patients with a germline BRCA or BRCA-like pathogenic variant, somatic, or an HRD positive tumor will likely have a clinical benefit. And that's the reason to be doing this testing. But all women should be offered a PARP inhibitor regardless of germline or somatic status, as there are PARP inhibitors that have indications regardless of pathogenic variant. So it's interesting, as I'm saying, this new information is coming out that the FDA is looking at PARP inhibitors for active treatment, and that may not be current. But this focus group was focused on first-line maintenance and first recurrent maintenance. So that's why this is really important, because even patients that don't have a pathogenic variant or a somatic may still be offered a PARP inhibitor. But we do know that the ones that have a pathogenic variant or mutation or typo, whatever term you want to use, that those are the ones that are going to have most likely a clinical benefit. But that conversation needs to be had with the patient, why you want to give this, and then again, the side effects that are associated with these medications. And then finally, people who do the hard work of obtaining authorizations may or may not be the patient's nurse or healthcare provider. Therefore, the challenges with authorization denials, appeals, out-of-pocket costs of medication, and utilizing copay assistance programs are all part of the challenges to providing important medications to these patients with the goal to improve survival outcomes. So again, it can be very time consuming, but it's also very important because our goal is to help our patients live longer and live better. And we now have medications that can potentially do that.
So based on the focus group's findings and feedback and recommendations, what additional training and education do all oncology nurses need to address those knowledge gaps or gaps in information about biomarker testing and PARP inhibitor therapy?
Well, I think I'm being redundant. I apologize, but we definitely have to assist nurses in their basic knowledge of why PARP inhibitors are approved and highly recommended to women who have a germline pathogenic variant or somatic or HRD, HR deficiency. And again, just taking ovarian cancer out of that, there's other cancers where you're looking at biomarkers and that will dictate treatment. So again, we're focusing on ovarian cancer, but the genomics and the biomarkers are so important now in who is going to be recommended a specific treatment. So that's where we talk about personalized medicine. It's really, really important. And we know that patients that have these alterations in their DNA repair, that PARP inhibitors can assist in preventing the cancer cells from replicating.
So what types of educational resources, both either for patients or providers, are available that you would recommend?
Our nurses are so educated and intelligent, but we also know that new information is coming at them every day at full force. So I don't by any means want to reflect that nurses aren't smart and up to date, but that information is overwhelming. And like you said, they're working 8, 12 hours a day And some nurses go home and they're still doing work despite having families and other things. So I think it's really important that we insist in streamlining new drug information, including biomarker status, mechanism of action of new drugs, so we can lessen their burden. I believe short CEU courses, 15, 30 minutes, educational series may be helpful. The nurses in the focus group reported that they would love one-page education cheat sheets or pearls of knowledge that include testing, ordering, mechanism of action, diagrams, as you and I mentioned, one-page handouts to give patients also that can reinforce the education that nurses are doing to help reduce the extra work on behalf of them.
We will include links to these items in our episode notes for today, but there are a whole host of resources that ONS has been proud to create and share with our nurses just to help bolster that education about genomics and precision oncology. And so there's a whole long list of new things that are coming out every day, it seems, in our learning library. So we'll be sure to include those links for reference as well below. So Paula, do you have any final thoughts or comments to share with us today?
Well, I'm going to make a plug for what you just said, because ONS is a great resource, as are the NCCN guidelines. But ONS, and I had nothing to do with it, so just my unsolicited bias, they have a new genomics and precision oncology learning library with a new biomarker database, and it's for certain cancers and then what the biomarker is. And it's being updated every single day. It's a ton of work, but it's such a great resource. So I can't emphasize enough for all of you to go and look at that. But again, as my final comments, there's clinical updates that will be available on ons.org that provides a text summary of our focus group discussion. And we encourage all the listeners to read and share with their colleagues as well. In addition, we are interested in receiving additional feedback from our listeners on this topic. And within the episode notes, as Jamie said, there will be links to a very short survey asking for any additional comments on these findings and how they compare to your practice experience. So please complete the survey to add your voice to the conversation. All the feedback just helps us strive to do better and improve. And again, this focus group was so amazing because in a sense, it takes a village, but we all do things differently. But their goal is to do it well, and we can learn and share from each other. But on a personal note, I am just so grateful for the nurses who dedicated their time to this focus group. There are many patient champions, and they were all present on that day when we had the focus group. They were dedicated to their patient outcomes, and they really want to make a difference. Again, the practitioners shared their knowledge and strategies on how best to care for our patients, and they were so passionate. And again, when they were sharing their frustrations, their energy was just so contagious. So I'm just privileged to be amongst this group of expert professionals and patient advocates from across the country. I mean, truly, what a gift. And Jamie, it's been just a wonderful pleasure working with you as well. So thank you.
Well, I think it's clear that hearing directly from our oncology nurses in a focus group discussion really provides a rich and insightful perspective on those real-world challenges and opportunities to improve the care that we provide to patients. I would also like to thank the nurses who participated in our focus group discussion. And of course, thank you, Paula, for joining me today and sharing their insights.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.